Good afternoon. Thank you all for being here today on the third of our Mondays in March sessions this year. Thank you for tuning in. Before we have Ms. Sollenberger provide an update on the health system, just want to remind you that next Monday is the last of the series, and we'll have the three EVPs with me up on the stage. We'll do a brief recap of each of the presentations focused on the high points, and then respond to questions that have been submitted to us or any that come from the audience. I think we've had 7 or 8 submitted so far. I saw a few of those. They're very good questions. So please continue to think about what you've heard or any questions that you have and get those submitted, or bring them with you to next Monday's session if you can attend. Dr. Jacobs did a great job following the precedent set by Ms. Cedro. My takeaway messages I took from his presentation: the academic enterprise has made great progress on major goals. It's improved in all of the mission areas: education, research, and patient care. Very much involved in the formulation of the clinical strategic plan and engaged with the health system and institutional support, and moving forward with the creation of tactical details. The research strategic plan continues to be vetted, but really in terms of its tactical issues, not so much the strategic issues. The education high-level plans that were formulated as part of AE 2020 are being attended to, and there will be some additional detail added with the formulation of a specific education strategic plan beginning with the first of the next fiscal year. So all in all, the academic enterprise is doing well. It's meeting its financial targets. It's meeting its recruitment targets. And so I think Dr. Jacobs had a very positive message for us. Thank you, Dr. Jacobs, for that really great presentation. So Ms. Sollenberger, please proceed.
Good afternoon, everybody. I was thinking today, I thought, gosh, how many of these have I done? And this is the 8th Mondays in March that I've done. So each one, I begin to start thinking about it right after the holidays, the winter holidays. And each year I think, I hope I'm able to tell you the things that I think we need to all be thinking about and doing. So before I get started, I did want to mention, I know Charlotte in our office was out there handing out these one-pagers. I'm going to not go into a lot of details going through all the things we've done and all the things we're working on, because they are many. But we try to do this to at least highlight some of the bigger things that we're working on that are taking your time and your colleagues' time and my time. So we have lots of achievements in the past year. I was thinking about it. Since we met last, we've opened the Jenny Seeley Hospital. We've opened the League City Hospital. We had just had Joint Commission. So we had a pretty big year, and then we decided it would be topped off in January with a fire. And before I go any further with that, I just have to tell you, being here that day and watching how everybody just got into action, everybody at every level of the organization, and it was like, tell me what I can do. The fact that we got 110 patients out of a building that there was fire but a lot of smoke, and we got over 200 staff and physicians out, is a testament to the incredible work that everybody does here. I was telling my family about it the following, probably the following week. And they said, well, gosh, Mom, we didn't hear anything on the news about it. And I said, you didn't hear anything on the news because not one person was hurt. And our sickest and most vulnerable patients, half of those were the sickest and most vulnerable, the infants out of the NICU that we evacuated. So you all deserve a great round of support. And even if you don't walk into a patient room, I see Frank Reigard and his team here ordering us and getting us what we needed so we could get back on track. See Mike Schreiner and a lot of his team here making sure that we were able to adjust where we were seeing our patients. And thank goodness we had the Jenny Seeley Hospital open. I saw Todd, there's Todd, making sure that we could move and find our patients in the new locations and continue to do our documentation. I see Dr. Richardson and Dr. Hankins and all of their staff and Cheryl Day. Everybody just did incredible work, long hours to make sure that we got through that. So thank you all. So today I was going to focus really on 4 things, and then we'll have time for questions and answers at the end. I want to focus on expanding our health system. I want to talk about some significant successes, which I've talked about a little bit. I want to talk about best care, and I know from Ms. Sadro's presentation, she asked who had heard about it in the audience, and almost everybody had. Is that still the same? Everybody here has heard about best care, so I want to talk about where we are and what our challenges are that face us, but celebrate some of the great work that's been happening, and then talk a little bit about the clinical strategic plan and the future of the clinical enterprise. So we've been expanding our footprint, and if you think about all the facilities that we have right now just to be able to see our patients, and particularly our inpatients, we have many, many new buildings where we can deliver the best care possible to patients. I also put in some numbers to really look at our growth, and people said, well, why are we growing? Well, if you think about up in the League City area is one of the fastest growing areas in Texas. Angleton-Danbury area, the Brazoria County area, is another fast growing area. So as we expand, we really look at the marketplace and say, what does it need? What do patients need? What are we lacking in that market? And to the extent we can fill in and help to provide patient care in areas where they are underserved, that's really what we've been trying to do. And so you'll see our hospital discharges, we're projecting to be about 32,000 plus at the end of this year. Outpatient encounters, who here works in ambulatory? Any folks? Oh, well, they must be busy taking care of the 1 million patients that we saw. I mean, that's pretty astounding considering where we were right after Ike. It's a huge system. In fact, Deb McGrew constantly reminds me that it's sometimes hard to benchmark us because of the big outpatient volume we have. And when we look at ourselves relative to other academic centers, there are only about 4 that have that big of an outpatient presence. And that's going to really, it has served us well and will continue to serve us well, and I'll talk about that a little bit later. Emergency room visits. Is anybody here from the ER? There. Well, your volumes have been off the charts. You guys have been taking care of many, many patients as they go through the emergency room and doing a wonderful job at it. In fact, I was looking at, the patient satisfaction scores. I was a little concerned given how overwhelmed the system is, but you're doing a great job there keeping the patient's throughput going and making sure that the patients feel well cared for. We've also been doing more transplants with the arrival of Dr. Jeff Fair 2 years ago, and you can see we jumped in the numbers, and we'll probably end the year right around 100, which is much better than the 40-some that we were having before Dr. Fair got here. Outpatient surgical cases, projections are they're going up. Inpatient surgical cases, that shows a little bit of a decline, but put them together. Why would I not be super worried about that? Does anybody know why if outpatient goes up and the inpatient's gone down slightly, why would that not bother me as much? Do we know? Yeah, we're trying to do more and more, the more we can on an outpatient basis, because it also it's better for the patient. You know, avoiding a hospital stay is always good. And the other piece is that as care gets, we're able to handle more and more care in the outpatient setting, we can move it to a less expensive place to be able to safely take care of that patient. So that's a good trend as well. Now, I mentioned some of the significant successes in the 2 hospitals, but we also opened 6 clinics. We opened the Wound and Hyperbaric Care Clinic. We opened the Urgent Care Clinic in Texas City, which I hear is very well received. I saw Ann, she's nodding her head. Adult Primary Care in Webster, which is terrific, and then we added Women's and Surgery to that location. We've opened the Angleton Danbury Urgent Care is in the process, and surgical specialties, we've also been adding a number of surgical specialists in that market for outpatient care. And then the Women's Health Clinic in Friendswood will open soon. And then we have the Ioneer Center over on 6th Street through a fabulous remodel that our folks from facilities worked with us on, and it turned out really, really well. So we continue to expand. We successfully completed a Joint Commission survey. Honestly, I think it was about one of the best ones I've ever had, and I won't even tell you the number of those I've done because it's too many. But everybody did a great job. We've started the modernization of the John Seeley Hospital, and we're doing it a tower at a time. And so, again, working with our colleagues from facilities in particular, we are on track to be able to get that building modernized so that we can have a place that's every bit as nice for our women's, infants, and children as we have for the total adult population. And I think people are really going to be pleased when that's done. We talked about the fire. We've also created new alliances. We've had many people who work on that with us, from Ms. Cedro, Becky Korenik, Tom Riley, Dr. Vicente Resto, Jeremy Brines. So many people are working on how do we make ourselves relevant to partners. And we this year created the MD Anderson Alliance, and they actually have a building under construction, an outpatient cancer center, and we will be part of that outpatient cancer center. We will have a 10,000 square foot clinic in there. We closed a deal so that we are a part owner of the Regent Care Center. There's a nursing home on the road behind the League City Specialty Center, and it's between the town center and the specialty center. This nursing home is Regent Care, and we have just bought a small interest in that because as we start thinking about caring for patients in the best way, in the most logical place, and giving considerations to cost of care, when we can establish these continuum that we can work with for our patients, it's going to help make us much more attractive as we get more and more into being responsible for managing all of the care of the patient, regardless of where they are. So that was an important step. We signed a clinical affiliation agreement with the Baptist Hospitals of Southeast Texas, and they have a number of specialists that they're interested in us either bringing or hiring into the market to be able to care for patients in that area. And then we have a partnership with the Memorial Hermann Health System. They have acquired leased some land actually at a place called Pinnacle Park, and to give you some context, it's a big open acreage just south of where our pediatric specialty and primary care clinic, dermatology is, and the HEB by League City. You'll for sure know that. So they're going to be building one of their convenient care centers, which is a place for primary care, urgent care, and they also eventually expand them to include freestanding emergency at times, and that will probably happen, and then a surgery center. And so they asked us if we would be interested in providing the pediatric primary care there, as well as the urgent care. So we've been working with them on that. And, why is that important? Well, I think it's important because we have the doctors in that market. If we need more, we can hire those. And that means that that really elevates the level of care that can be received in that community. So we've been doing a lot of these so that we create linkages that will make sure that we can continue to access the patients that we need, that need our care, but also as we think about progression of disease where they may get sicker, they actually can come here. All of that's good for our mission of educating students, as well as it will allow opportunities for clinical research. So we're very excited about that. Now, last year I talked about making the quantum leap in quality that Chancellor McRaven had asked us to do, and we have since then defined it as best care will be delivering the right care at the right time in the right way for the right person and having the best possible results every patient, every time. Some people have said, Donna, do you really think we're going to be perfect? I hate to think that we are not, because there are people at the end of that depend on us to be doing the best possible job for them at that time, whether it's care or comfort, treatment. They need us to be sharp, to be doing the best possible job that we can. So I'm not going to tip to the we can't be perfect argument. I think our goal every day, and I think it's yours too, when you come in, is to make sure our patients get the very best care possible. And so we will continue saying it's got to be every patient, every time. We started measuring how we were doing. And there are 6 domains to what we're looking at, and I'm going to talk about each one briefly. So we have equity of care is one of the domains. We have mortality, efficiency, safety, effectiveness, and patient-centeredness. And each one has a percent by it. If you can see that, I think you can. That's projected pretty well. And that tells you of your total score, what does that particular, they call them domains, topic area, what does that represent? And so you can see that some represent a lot more weight than others, particularly with mortality and with safety, although all are very important. So let's start with the ones where we're doing well and we just need to continue to do well. Equity of care, that means we're delivering the same care, same treatment, despite any differences in age, in gender, in ethnicity, payer status, race. No matter what, the patient in front of us, we are going to give them the same care consistently for that. I think we are number 1 in that, so we're tied with a whole bunch of other places, actually about 80 of them. But I think that that's a good place to start, is to say that we are going to treat everyone that we come in contact with who needs our care, we're going to treat them equally. So it doesn't count for a lot of weight in the scoring, but it means a lot, I think. I think the impact of it is important. Patient-centeredness, we've been doing well there, and that's measured by the Press-Ganey survey. And then there are 8 questions also that the centers, that Medicare basically reimburses us on how we perform in those areas. And you can see there are a number of areas that they rate, from communication to how well your medication was explained, to how clean and quiet was the environment that your care was delivered in. These are all inpatient metrics. We don't have outpatient yet, but they're being worked on at a national level, and I wouldn't be surprised in the next year or two to start seeing best care metrics for outpatient as well. But we're doing well. If we look at our rank the last time, we were 21 out of 102, and we've actually improved over the last year since this last study came out. So we believe that on patient-centeredness, we are really, and you'll see some numbers in a moment, we're doing well. The next one is mortality. Now, this is looked at, they take the total number of people who died in your hospital, and then they look at, of those, given the diagnosis, given the situation, how many of them would be normally expected would pass away, regardless of your intervention. So it's called the observed, that's the number that actually did, over the expected, so that's the number that actually, if you looked at the condition, we would have thought they probably would anyway. Now, we didn't score so well in that, and especially if you look at our ranking on 102, and you may think, oh my goodness. But I want to spend a minute on this because I think it's important for you to understand. This is not reflective of the care that's really happening at UTMB. And you're going, well, the patient passed away, didn't they? Yes, but what we have to look at is what did we expect versus what did we observe. And when we started looking at it, and Dr. Sharma and so many people, Mark Kirschbaum, have worked very hard on this, and they did, the peel back the onion thing. And guess what we found? We weren't documenting how ill the patient was when we got them. And if we don't document it well, can Emily Gertz's coders make a difference? Can they change that? Of course they can't. All they can do is code what was documented, and then it goes in and looks as if that patient wasn't as sick as he or she was. Dr. Sharma tells me in any given month, we need to be below 20 deaths in the hospital. And this past month, we were, if I remember this right, 15. And we've been below 20 for the last several months. So what happened? We have done tons of education around documentation. We have collaborated with the clinical documentation specialists in the health system, with Emily Gertz's coders on the revenue cycle, lots of coordination going there, lots of education. And we have also opened hospice care. So when a patient is transitioned to hospice, they go out of the whole equation. So you're not going to get dinged for having a death in the hospital, because if they're in hospice level care, then it doesn't mean they're transferred. Hospice level care in the hospital then they don't count in that. And we were not doing ourselves any favor in any of those fronts. And so much work's gone into it. And I'm just excited to see how we perform in the next survey, because we have been really pushing very hard, looking at this. And we want so much for the reporting to reflect the work. And right now it isn't. And I think it is in the past few months, but in the last report it wasn't. Effectiveness. This is really processing and thinking about the desired outcome and experience of the care. How effective were you in delivering the care? And so we look at how many patients were discharged from the hospital and within 30 days had to come back, because that's basically an indication of many things. On readmission, if a patient leaves and then develops something else and has to come back, did we do the job as well as we could in the first place, and did we discharge them at the right time with the right support when they went home or to their other level of care? So as we look at that, we again have some work to do. It's 20% of the score. We're 47th. That's in the higher end of little bit higher than the midpoint on the study. But again, tons of work going into reviewing every readmission. Could we have done things any differently? And I think you're starting to hear there's been a lot more focus, a lot more depth going into effectiveness. Efficiency is the fifth domain, and that's basically, are you doing the right thing in the right setting, and using your resources as wisely as possible. And we measure generally that by the length of stay and the cost of care, and it's a 50-50 split between looking at length of stay and looking at the cost of care. And we have, again, been doing a lot of work around that. Dr. Rookneen and Deb McGrew have been doing work on looking at the length of stay and what can we do to improve that. David Marshall and so many others have been working on improving care management so that we are making sure at the beginning of the patient's stay, if it were a regular course of care for a patient with that condition, how long would we expect them to be in the hospital, and trying to transmit that at the beginning of the stay so everybody can coordinate their work around that expectation. It's helpful for the family and the patient as well. And then patient safety, and these are really, we're trying to focus on zero errors and complications, and they can be things like pressure ulcers, they can be things like central line infections, they can be things as catheter associated urinary tract infection. I love all those have acronyms, but I like to try not to use those because I want everybody to understand what we're working on. And again, while we actually did pretty well in that, that doesn't mean we can let our foot off the accelerator. In fact, there are a number of areas where we can continue to do better. So the results, what does this look like? Well, what I did was I put up what is the area that we're looking at, what is the biggest measure within that domain that we're working on, how did we perform in quarter one, its goal, quarter two, the goal. We now are going into quarter three, and then I put in the quarter four goal as well. So we set it up so we had to improve throughout the year. We didn't wait till the end. So I think that's important. And as you can see, we're doing quite well. We have 4 of the domains where in quarter two we performed well. And we have a couple of domains like effectiveness, and remember I said that measuring length of stay. We didn't meet it for that quarter, but as Dr. Sharma is always quick to point out, if we look at the 6-month number, we made it, and so they'll be looking at all 12 months, so it's important we continue to make progress. And then the central line infections, we had a little bit of a blip, and we actually reviewed all the units. We found where we could improve practice in a very targeted way in some areas, and so that's what we're doing. So one of the things people ask me all the time is, how do I participate in best care because I'm not a clinical person? So I don't ever see a patient. I don't ever go into a patient room. I can't really affect best care. I mean, it's great you all are doing that, and I hope you get there, but I don't really impact it. So I've been thinking a lot about how I could demonstrate that today. And I'd like you to watch this little video that we did and look at how many people touched this product you're going to see in a second versus how many went in the room. And what happens when the other people, and try and count the number of people that we see actually handling. How many people did it take who never go in a patient room to be able to make this patient get the care that they needed? more engine. I don't know, you were on those carts. And I want to say we are more efficient than that. I told them, we don't usually use one of those big trucks to transport a single box. But they humored me that day so we could make the point that we wanted to make. So think of all those points. I'm going to make one other distinction. How many work in areas that were represented in this video? Okay. How many of you are in the health system that touch those that would be in that part of the video, that would be in the SICU? Okay, the people who raise their hands don't work for the health system, do they? They work with us, though, don't they? We all work together to make this work. And we could have made this go even further, Frank. I was thinking about this. It could have started when they ordered from the unit what they needed, and purchasing needs to make sure they have good, reliable vendors that can get us what we need when we need it at a good price, and that we go through the whole purchase order process, and we could have also put accounts payable because somebody has to pay that. So there were so many more. We had to stop at some level. But I wanted to make the point that so many people who make patient care happen, they don't walk into patient rooms. So have you ever heard about the 6 degrees of separation? The idea that everything in the world is now 6 or few steps away from each other. So that chain, that friend of a friend, well, it was a game that started by John Guare. And anyway, my kids taught me this game, but they called it the 6 degrees of Kevin Bacon. Remember this? And the thing is that you name an actor and you see how many other actors do you name before you get to a film that Kevin Bacon was in. And it actually works. We tried to do this one Christmas. It was kind of fun. But anyway, I wanted to talk a little bit about our 6 degrees of best care. So I've got our special events people here, and I want them to stand. Where are you? There you are. Okay. They do magnificent jobs with every event we have. But someone said, but special events doesn't really impact best care. So you guys can sit down now. Thank you for being here. But I'm going to show you, oh, you really do. So do I have our development people? Could you stand? Awesome. I don't know if you've ever been to any of their events, but they're amazing. But do you do all that stuff yourselves? Who helps you? Special events. So special events is development is a customer of yours, right? Okay, sit down and thank you for all that work. By the way, Dr. Callender had mentioned, finished our Working Wonders campaign, $450+ million. You guys are great, all of you. So development does this so that they have people who will give money. That's your purpose. And the picture here is of Mr. and Mrs. Ross, who gave money. Also, Mr. Ross was one of the co-chairs of the Working Wonders campaign. And what do you think they gave money for? Just yell it out. The Jenny Seeley Hospital, okay? And so they wanted to make sure there was a really top-notch facility in Galveston to be able to use. So the Jenny Seeley Hospital, now we have a much better environment for us to be able to more easily deliver care. So our nurses and our physicians and our staff, our trainees, all benefit from the generosity of people like the Rosses and maybe people like you, because we raised $11 million in the family campaign, and I still have people from Austin asking how that happened, because that was really pretty remarkable. And those nurses and doctors and staff actually benefit the patient. So it's a little bit different way of thinking about following the box, but even if you put in some place that you don't really think, well, no, I don't really touch the patient, I think you can do it every time. So you are all involved, And I just wanted to wrap this up by saying all of us need to commit to best care. We need to work in teams that are going to make sure that we have the best patient experience for the people and for our customers, the patients. We all demonstrate leadership, formal and informal, in trying to elevate the level of care and the experience. We have to maintain our focus when we are delivering best care, making sure that when the patient is there, we're focused on them. We have to continue to use our resources wisely because there's really not a never-ending stream of money. So we have to think about our resources, and our people are a resource, and our space is a resource. So we have to think about all of that. The one thing I want you to really, really remember is if you see something you think is an error, something that will cause a problem for that patient, please speak up. And if you're the one who is in the process of maybe doing something that the comment is directed to, welcome that comment. Because it's only said to be able to make us stop for a minute and think, is this really what we want to do? Sometimes it is, and it's fine that the person asks that because we reassessed, yes, this is what we want to do. But other times we may go, oh, you're right. That could cause a problem, so we need to rethink how we're going to approach it. We want people to feel comfortable doing that, and I know there's still mounds of work to do. And I want everybody to feel comfortable to speak up, and everybody to feel if something's being pointed out that I'm doing, that it's not going to necessarily, it's not reflecting on me as a person or my quality. We're all like one step away from probably not doing what we need to have done. So let's receive that well. And everybody can warmly greet our patients and visitors, and I have people tell me that all the time, how great UTMB is. I want to quickly touch on the clinical strategic plan. This is in draft. We have talked to a lot of people. We're going to be talking to more people all the way through a session in March where we're going to have a lot of people in a room to give us feedback. We want this to be an inclusive clinical plan. But we need to have this. We need a roadmap because the last one we had, we developed in 2015. We actually met all the goals of that. But now we need one that's going to help position us to be able to do very, very well in a rapidly changing environment, and that UTMB is known for being able to do that. So we want to create the future of the clinical enterprise, and we're doing it because also our education and research missions, we need growth and we need reinvestment to be, so we need the clinical enterprise to make money so that we can reinvest it in our missions as well as in patient care. And to do that, we're going to need to be attractive to payers, which means we're going to have to take a really hard look at our cost and our quality to make sure that we're doing well. So our 4 work groups did some work around the patient experience, operations, and the value of that, growth, as well as value-based partnerships. And under the patient experience, we found 3 areas where we wanted to emphasize. We can always have a real long list, but go back to focus. So we need to say, what are the 3 things we could do that are most likely to have the biggest impact? So we talk about, in the patient-centric culture, that you're able to have consistent hiring and training. So the people we're bringing in and the people we're retaining are the people who really resonate with our mission. And then we also need to think about access and how do we transform that so we're open for convenient hours for our patients. In primary care, they could get same-day access, and they can have some guaranteed appointment times. And then lastly, under the patient experience, we want, it says retail payment options. That's just when you go to buy a car, there's a label on it. Now we can negotiate, but it tells you how much that car is going to cost you. We need to be able to make the same kind of estimates for the types of care that people will seek us out for, because that's becoming increasingly important to patients as they're responsible for more and more of the cost of their care. Under the operations, we said we need to have data-driven management so that we have, and we're working on the UTMB Discover to create a warehouse where we'll be able to really easily get at our costs and our outcomes. And so that's going to help us make our decisions based on fact, not conjecture. And I think that's going to be really powerful for us. We also need physicians empowered to align with us in the goals that we set out as a health system to make sure that we can have the very best results. And I know we've been doing more and more of that each year. And this year, I think we've especially had that level of engagement and alignment with the academic enterprises. We have worked on best care in particular. We also need to have high reliability operations where we are consistent in the way we deliver the care and we use evidence that shows how we can reduce variation and cost. On the growth, we are going to look at an integrated neurosciences service line to emphasize to start. That doesn't mean definitely wouldn't mean we don't invest in other things, but we want to start out this year for the remainder and for the next couple of years with a real focus on integrated neurosciences, because when we look at our patients, that's also going to help all of our colleagues that work in the areas of heart and musculoskeletal, because those patients often need those services. And that means also we're going to have more rehabilitation services and neuropsychiatric services, because those are things that we would need in an integrated service line. We're also going to look at incubator types of growth, where these are rapid cycle, low risk ways that we can improve our care. And one of the ways that we're doing that as a bit of a pilot is, can we bring eye and ear together into more of an institute or center feel, which I mentioned we've done on 6th Street at the Eye Center, and we're going to be looking at other ways to do that. Not a big service, but it is an incubator and allows us some experience too in getting ready for that and meeting a need in that community. On provider partnerships, clinical integration, we need to have, remember the Regent Care I talked to you about, and we need relationships with home health and with skilled nursing facilities and with long-term care, acute care hospitals. So the more relationships we have where we can actually care for our patients in a multitude of settings, the better off. And then utilization and risk management we need to emphasize, so that people who are the high utilizers of our care have the most robust management, because it would be it's easier for them to come back to the hospital or even to the clinic when we could have done other ways to help manage, and they would be managed better in the various other places, whether it's their home or one of the other types of services we provided or talked about. And then lastly, provider relationships. We want to have more high-quality relationships like we're talking about with MD Anderson. For regional providers, the more we are part of a greater network, it means the more patients that we're seeing and we're responsible for. And Becky Korenick has made me a believer, just like the monkeys. I'm a believer now that the larger we get that base, the more attractive we're going to be to payers. And so we need to be thinking about those relationships all the time. So we have a number of critical success factors, but notice words we've used today already: focused, aligned, engaged. We're going to require accountability. That's but are people doing what they are supposed to do within this chain? We're going to integrate and accelerate decisions, because we're going to have to get better at that, and that's where the data access will help us. And then finally, we need to continually improve our processes. We can celebrate when we had a win, but we have to keep moving. So the remainder of 17, just on a very, very high note, we still have nursing magnet recertification this summer. It's been 4 years, unbelievably, and that's a very important designation to us, because nurses, it reflects the quality of your organization, but nurses who work want to be in a magnet organization. We're preparing the FY18 budget. Yay, we're doing that again. I'm trying to eat my Wheaties to get ready for that one. We're looking at expanding the League City campus, and there's a lot of work going on in that regard through the end of the year. We will continue the drumbeat of best care, focus on that, and then concentrating on our efficiency of care and operations because, as I said, no unending stream of money that is coming in. So we're going to have to figure out how to do this as efficiently as possible. So what do I want you to remember from today? I want you to take away a good message. Notice that I entitled this Best Care, Bright Future. It's not going to be easy, but I honestly believe, without a shadow of a doubt, that we do have a bright future. We have so many positives going for us, and if we all pull together and pull them together, our future is indeed very bright. The growth makes us more relevant to payers, to patients, to businesses. That's critical. Second, current and future partnerships make us more attractive to patients and payers. When people say, why do this MD Anderson thing? Well, we have a great oncology program, obviously. We have great oncology care, but it allows us access to other types of clinical research protocols that our patients can use, and we have things we can contribute as well to MD Anderson, and they've agreed with that. So we need to make ourselves relevant and attractive. Best Care is going to make us more competitive because we will have outstanding quality results. When we get to the end of August, our goal was to be in the academic medical centers that participate in the Vizient study. Our goal was to be in the top 20. Trust me, that's a very good group. And a year ago, I had some hesitation. I have no hesitation. I have never seen an organization come together to work on something, and I wasn't here during Ike, so that's probably number one. But this one will be a good one because it's going to help us show the real care that we're giving to our patients. The clinical strategic plan is going to provide us focus and future direction. The success is only possible through the teamwork. Think about the video we had of the box. And then I think your whole leadership believes while our future is challenging, it's also bright. We've taken care of populations of people since we started taking care of patients in the prisons. That's population health. We have found ways to deliver that in effective, meaningful ways. So we have a very bright future, and it's only because of all of you. Every time you agree rather than grumble, I'm going to be thinking, how can I help? Where can I make a difference? And how do I impact that patient? Because at the end of the day, that's really an important, very important part of what we do. So I want to thank you for everything that you do each and every day to make our work possible and to make our patients feel that they are indeed coming to UTMB and getting the best care, the best outcome, the best experience possible. So thank you all. And at that point, I'm going to see if we have some questions.
Hi, everyone. My name is Dawn Meyer. I am the vice chair for the Employee Advisory Council, and I represent the hospital and clinics, and we did have a couple questions.
Okay, great.
The first one is, my son is a patient at UTMB, and it is often my husband who takes him to his appointments. I was surprised and disappointed to learn that the men's restroom in the Eye Center in Galveston does not have a changing table. As an academic medical center, I believe UTMB can and should be a leader in non-discriminatory healthcare policies, which should include providing these same resources to male and female patients.
And I saw that, and I could not agree more. In fact, I kind of thought, shame on you, Donna, for not being the one to see that. But I don't usually go in the men's room, so So shame on you, Dr. Jacobs, for not telling me. Mike, could I ask you, because I asked Mike Schreiner about this, and I mean, within minutes of sending that, he told me what they're going to do.
Well, in fact, we appreciate the comment because it's one of the things we want to do is make sure we continue to upgrade the standards of our design for all of our facilities. So this is a fairly easy one. To grab that topic, make sure we can update our design standards for restrooms, male and female, and probably a few others. And we'll have those addressed fairly shortly.
So I think the person sent that in anonymously, but if you're within listening distance, thank you for doing that. Have another question?
Hi, my name's Jill Bryant Bova. I'm also a representative for the EAC with hospitals and clinics. And this is from an employee from the mother-baby unit. They quote, "With recent changes in mother-baby unit, our staff feels very pressured. We are required to follow the orders we get in emails which do not reflect doctor's orders or protocol. We are pushing patients out even when there are open beds. We have expressed our concerns to our leadership, but are hoping for higher leadership attention."
Sure, thank you. Well, first of all, I did one of the things that when I read that, I thought, oh my gosh, we're not doing orders through email. That's not what we do. And delivery of care orders are not, I'm told, being done through email. But I did talk to David Marshall, and I would like him to give you a little bit of an update because we did have a big change.
Across the nation, hospitals have moved from what, you know how you see on TV, old nurseries where you go up to the window and see the babies. They've moved from nurseries and postpartum units to mother-baby units where patients are cared for in a dyad of the mother and the baby. We've undergone that change at UTMB over the past couple of years, led by Tracy Santiago and Deb Mordecai and our physicians from OB, Dr. Hankins and Dr. Richardson. That's a tremendous change. When you read the literature about other hospitals that have gone through this change, it's gnashing of teeth and changing hundreds of years of tradition on the parts of nurses and physicians. We've experienced some of those same issues at UTMB. I think as a leader, I underestimated the change support that was necessary to help us move through that. And we've looked at that, addressed that, and provided some more support. And I think what, as I've looked back and talked to Deb and Tracy and Dr. Richardson and Dr. Hankins, what the person was saying about the orders is that we still have admit to the newborn nursery orders that exist in our electronic medical record system. We don't have a newborn nursery anymore. So it's hard to follow those orders when you have a new baby, and we just haven't caught our orders up with our practices. And I think that's probably what they were talking about. But we do realize that it's been a huge change. It's all done to benefit our babies and their families. That's why we undertook this change, not to stress people out. But it has been stressful for people, and we're redoubling our efforts to put the support in place that's necessary to get them through this change that we really need to do for our babies and our moms.
Thank you, David. We have had a tremendous amount of change, and then they were the ones most affected. And I did, just when he started talking and said Deb Mordecai, I apologize, I called you Cheryl Day. early on. But no, Deb and Dr. Hankins and Dr. Richardson and so many others helped us during that difficult time. I hope that answers the individual's question, but if not, you can re-email EAC and we'll give you more in-depth. Okay, we have one more question. Time for one more.
Hi, I'm Lori DeWillis, and I represent the academic enterprise on the EAC. So here's the question. It's difficult but critical to manage customer perception. I know we're doing best care and also conducting Press Ganey survey responses to gauge feedback, but in reviewing our general Google reviews, the most recent 6 in the last month are distinctly polarized at 5 stars and 1 star respectively. In conversations with friends and family related to their health care at UTMB, I'd like to be able to share a method to effectively communicate their feedback and resolve any concerns if needed. What is the best method patients have to discuss items related to care?
So our best method is to make sure that your care team is aware if you have any issues as a patient. But also, if that makes you uncomfortable, and I can see where that might, another avenue is our Department of Patient Relations. And in every room, it indicates that these folks are available and they will advocate for you. So that is another avenue and the one that's used most often. Now, all that being said, we have a number of ways to measure how patients feel about the care that they have gotten. So the writer is correct. Press Ganey gives us not only an overall view of how we're doing, but there are many free text comments in there, and we actually go through those and make sure that there's not something in here that pops out that we should try and take care of. Many times those are anonymous, so it would be hard to do, but we look at them for trends, thinking that may help us find ways and places to improve. And we do also the AHRQ Leadership Survey we administer so that you all and everyone in the UTMB family can take this survey to say how safe do you think care is here? Would you refer a friend here? Would you come here for your care? And so those survey results are used to develop improvement plans for the areas that have the highest need for attention because we didn't perform as well as we would have liked. But any of the means, whether it's reputation.com or the one in Google, all of those are means for us to take a minute and reflect, because most of the time, vast majority of the time, we do a really good job. But for those who've interacted with our system and they are not happy with it, we need to step back and say, are there things that we can learn from this individual's experience that are going to be helpful to us in seeing that future experiences are that much better? So hearing from people, if I'm in the grocery store and someone comes up to me and talks about that, I assure them I will look into it, I will get back to them, and I do. And a lot of times I say, is it okay if I call you? A lot of times that person will say, sure, I'd really like to know someone followed up on this. And most of the time what they want to make sure is not they're grumbling, they're really trying to help us. And so when I call them back, they're always pleased that we actually looked into it. I can tell them what we did, and they are appreciative that they were heard. And I always thank them for helping to make the experience better for all of our patients. And while we failed in that regard, we are taking steps to address that. One lady in particular I remember wrote me this letter, I think she wrote it to Dr. Callender too, about a terrible experience in one of our services, and she was never coming back. She'd been a patient, she lived on the island, she was never coming to UTMB again. But she had her name, and so I called her, and I first started out by telling her I'd read her letter, and I apologized. What she described should never happen. But what I wanted to do was to hear from her experience so that I had an opportunity to figure out how we fixed it. And at the end of the conversation, she said, one, I can't believe you called me, actually. And secondly, she said, I know I said in my letter I'd never come back, but she said, the fact that you called and you care, I'm coming back. I'm going to continue to be a UTMB patient. So those disgruntled remarks that we get through Google, if we can figure out who they are, if they'll not be anonymous, but really tell people you encounter, we want to make a difference. We want every experience to be good. And when it isn't, we want the opportunity to figure out how we can improve it for the next time. Okay? We're out of time. I want to thank you again for everything you do. So appreciative of each and every one of you and the work you do every day.
UTMB Health, working together to work wonders.